In this WBT, we will focus on the different specialties within the enterprise middle revenue cycle. Let's start with professional revenue cycle management. This section will provide a brief overview of the Kentucky Medical Services Foundation, or what we refer to as KMSF, revenue management team and the services they provide. This slide illustrates the stages of the revenue cycle, also called the revenue cycle wheel. This is a good demonstration of how each piece or stage within the revenue cycle flows into the next. While some areas have their own department, such as utilization review, CDI, and HIM, the revenue managers look at each piece and how they impact the ultimate claim and payment. Each piece is important and relevant for timely reimbursement of services. The next 3 slides go into further detail on what exactly the revenue managers and the team do. This slide describes the quote-unquote, "What are we doing?" meaning what internally, as a university, department, or division are we doing? What exactly are we working on in billing? And how does this compare to budget, benchmarks, and other statistical data? Please pause to review the financial analysis. This slide details the quote-unquote, "What are they doing?" meaning what is happening outside of our walls. By looking at our accounts receivable, denials, reimbursement trends, and other outside information such as updated government regulations, how can we best adapt to this environment to be as efficient and effective as we can be? Please pause to review the reimbursement analysis. Here you will see how the revenue management team communicates and collaborates with each department. A revenue manager knowing what we are doing and what they are doing alone does not accomplish much, but communicating and working closely with our department customers and counterparts is how we can affect change. High-level communication occurs at monthly financial close meetings with leadership, and each revenue manager has monthly meetings at the department or division level. These meetings typically include the chief or chair, medical directors, division administrators, and practice managers. All revenue manager communication does not have to be formal. We encourage providers to reach out with questions or requests as we aim to be readily available to our customers by phone or email. At the end of today's orientation session, you will receive an organizational chart with your revenue manager's contact information. Please feel free to reach out as needed with any questions or concerns. One item that is reported on a monthly basis is timely filing of notes. UK Healthcare has a signature policy for ensuring all documentation is signed in a timely manner. Notes should be signed within 14 days of the date of service. On the 15th day, the provider will lose all work RVUs, and if it is a Medicare service, no claim will be sent out, causing an immediate impact to department financials. Work RVUs are lost regardless of payer. This is done since Medicare will recoup payments for notes that are found to be untimely, and we always have the risk of other payers following suit. All untimely signatures are communicated to leadership and at the monthly department meetings. In the lower portion of this slide, you can see a listing of reports that are available to providers to access on their own. If you go to kmsf.com, click on Faculty, found at the top of the page, which applies to all billable providers, then click Provider Reports. Here you will find the 3 reports available to you. The billing data detail provides all charge information down to the individual patient and CPT level. The individual provider dashboard is similar to the report discussed in the monthly financial meetings, but at the individual provider level. This shows charges, payments, and work RVUs along with accounts receivable information. The second page of the dashboard includes provider coding curves where current evaluation and management levels are compared to previous quarters and against national benchmarks. Accessing these reports are not required, but are made available to any provider who is interested in accessing their own data. We will now take a look at enterprise clinical documentation integrity here at UK Healthcare. Let's start with inpatient CDI. The purpose of a CDI program is to initiate concurrent and, as appropriate, retrospective reviews of healthcare records for conflicting, incomplete, or non-specific provider documentation. These efforts result in improved accuracy and completeness in documentation, coding, reimbursement, severity of illness, and risk of mortality classifications. We look to capture diagnoses associated with the Vizient risk models and compare those to our cohorts. Quality reporting is our mortality index and patient safety indicators. We want to make sure that we capture present on admission diagnoses. For example, a pressure ulcer. Was it there on admission? If so, then we are not quote-unquote dinged for that specific ulcer. If the ulcer is present on admission and we don't document as such, then that will count against us. Reviewing the documentation to capture CC and MCCs will increase reimbursement, and our CDI team reviews documentation in order to assist you capture those diagnoses. The outpatient CDI purpose is much like the inpatient, to improve provider documentation. The medical record should accurately depict the acuity of the care provided. It should demonstrate and explain why more resources were spent to treat one particular patient compared to another patient with a similar diagnosis who was managed and treated with less resources and intensity. CMS states that medical necessity is the overarching criterion for payment in addition to the individual requirements of a CPT code. HCC, hierarchical condition coding, is a risk adjustment model to calculate risk scores. The HCC model ranks diagnoses into categories that represent conditions with similar cost patterns. Higher categories represent higher predicted healthcare costs, resulting in higher risk scores. Capturing quality metrics is key to the enterprise and will assist in increased scores and revenue. In any CDI program, education is key and a must. The Enterprise CDI team is here for all your educational needs. Last but certainly not least, we will focus on enterprise coding. The professional coding team is a centralized business unit responsible for professional coding and charge capture. This includes chart abstraction and coding, pre-claim coding edits, coding compliance and charge integrity, clinical documentation improvement with partnership from outpatient CDI, EMR optimization, coding denial management, and revenue analytics. This slide shows the revenue cycle process for professional claims. As you can see, clinical documentation provided by the physician leads to coding and charge entry by the professional coding team, which then flows to billing within KMSF. Please pause to review the stakeholders and process overview. The hospital coding team is responsible for inpatient and outpatient hospital facility coding. The hospital technical component covers the cost of the equipment, supplies, and personnel to care for patients and perform procedures. Hospital data is used for core measure scoring, Vizient data, as we discussed during our Enterprise CDI slides, CMS physician profiles, patient safety indicator metrics, and other publicly reported data. Clear and consistent physician documentation throughout the EMR is essential, as this is what the coding professionals rely on for accurate depiction of services. Within hospital coding, the inpatient coding team focuses on chart abstraction and diagnosis coding, hospital DRG assignment, and codes for quality metrics such as PSI and Vizient data. The outpatient coding team focuses on chart abstraction for CPT, diagnosis, and HCPCS coding, hospital APC assignments, and review for medical necessity, CCI, and OCE edits. As you can see, both teams focus on coding compliance, regulatory integrity, and coding denial management. This slide shows the revenue cycle process for hospital claims. Clinical documentation by the provider leads to coding and charge entry by the hospital coding team, which then flows to patient financial services to manage billing, collections, and reporting. Please pause to review the stakeholders and process overview. This concludes our WBT. Thank you.